Druhým řečníkem, kterého bych chtěl představit, je Jaime Delgadillo, který je seniorním lektorem klinické psychologie na univerzitě v Sheffieldu, takže ve Velké Británii. Jaime ho zajímá hlavně, jak se liší lidé, klienti mezi sebou v tom, jak reagují na terapeutickou léčbu. A má to takový praktický cíl, jak vlastně personalizovat psychologické léčebné nebo tedy psychoterapeutické programy pro klienty, kteří, řekněme, reagují méně příznivě na terapeutickou intervenci. Tak já už dávám slovo Jaimemu.
I'm Jaime Delgadillo. I'm a senior lecturer in clinical psychology at the University of Sheffield in the north of England, where I teach clinical skills and research methods part-time. And I also work as a psychotherapist and clinical supervisor in the English National Health Service in a city called Rotherham. I've been in this career for about 20 years now as a psychotherapist. And during that time, like many of you, I'm sure, I have observed a remarkable variability in treatment response in my patients and in the patients of trainees and colleagues who I've supervised. And I think it's fair to say that I have become obsessed with this question. Why is it that some people respond remarkably well to psychotherapy? They start to improve in their symptoms and their social, occupational functioning within about a month of starting therapy. But other people actually seem to deteriorate during therapy, despite our best efforts, even if they receive the same treatment from the same therapist in the same clinic. So I have become very interested in this observation of variability in treatment response. And that is the central topic of this presentation. The main question that I will try to approach is, why are some cases not on track? Next slide, please. My colleague Kim De Jong already elaborated on the concept of expected treatment response curves and the feedback systems that are applied now in several countries in the world. On this slide, on the left-hand panel, you can see an example of a feedback graph that uses expected treatment response curves. And it's showing you an example of a patient whose trajectory of symptoms was not on track at around session 5 of therapy in my clinic. This person had depression and was receiving cognitive behavioral therapy. These are the types of cases that we tend to focus on in much more detail in the area of feedback. And as Kim explained in the previous presentation, these not on track cases matter a lot. For example, data from our research group in the United Kingdom indicates that these not on track cases are highly prevalent. It's not a rare event. It occurs, these not on track signals occur in around about 47% of cases in the setting where I work. Furthermore, not on track patients are more likely to deteriorate over time. In our treatment system, we find that not on track cases have approximately deteriorate 8% of the time. And that's compared to cases that are classified as on track who rarely deteriorate, less than 1% of the time. Not on track cases are less likely to reliably improve in their symptoms. For example, the reliable improvement rates in not on track cases we've observed are around 32%. And that compares to a much higher 55% in on-track cases. Furthermore, treatment for not on-track cases is not only less effective, but it is more expensive too, seen from a health services perspective. Not on-track cases in our system use an average longer duration of treatment. For example, the mean duration is 8.6 sessions relative to 6.3 sessions for the on-track cases. And we also know that patients who are not on track also are more likely to be taking pharmacotherapy, for example, antidepressant medication. So we know that not on track signals are a reliable way of identifying people with poor treatment outcomes and with quite expensive treatments. Why is it that patients are not on track? Next slide, please. As my colleague Kim De Jong explained, one of the more prominent frameworks for understanding signal cases or not on track cases was proposed by Michael Lambert and colleagues in the United States. And they proposed, based on theory and evidence in the field of psychotherapy, that when patients are not on track, this may be explained by one or a combination of the 4 domains that are listed on the left side panel: therapeutic alliance, motivation to change, social support, and negative life events. And of course, we have some very compelling evidence from randomized control trials and meta-analyses that when therapy is supplemented by feedback and clinical support tools that target these domains, a treatment seems to work better, especially for not on track cases. Now, we know that adding these clinical support tools helps, but is it all of these clinical support tools that are necessary? Are some of these domains on the left-hand side more important than others? Are all of them relevant? And these are the questions that have been approached by a small handful of studies published in recent years, which I will summarize now. Thomas Probst and colleagues conducted a clinical trial of feedback plus clinical support tools. Oh, can we go back to the previous slide, please? In 2015, Probst and colleagues did an investigation of associations between patients' responses to the assessment of signal cases questionnaire to investigate which of these domains was statistically associated with not on track signals that occurred during therapy. And this was in an inpatient psychosomatic psychotherapy clinic. They found that the domains of social support, motivation, and life events were significantly associated with not on track signals. In a more recent reanalysis of the same data set from that clinical trial, it was observed that specifically interpersonal difficulties that occurred outside of the therapy, for example, conflict with other people in the family network, seemed to be the most relevant and reliable predictors of not on track signals. Similar findings were reported by White et al. And Kim already mentioned the results of this study, so I will just point out that in this particular study, although it was observed that when there are alliance problems, they often co-occur with motivation problems, and when there are social support problems, they also co-occur with life events. It seems that the social support domain was particularly reliable predictor of not on track signals. Furthermore, social support, life events, and motivation problems seem to be endorsed by not on track cases quite often in a study by Wolfgang Lutz and colleagues, the last study mentioned on this screen. But they found that the last two domains, so that's specifically life events and motivation problems, were the best predictors of not on track status. So overall, if we summarize the fairly small literature focusing on the assessment of signal cases as a framework to understand why some patients are not on track, there is some support for most of these domains. Interestingly, the last three domains, motivation to change, social support, and negative life events, seem to have the most convincing evidence. Something that you don't see in this slide are references to therapeutic alliance as a frequent or highly reliable predictor. So that gives us some idea of what processes are occurring in situations where therapy is not on track. Next slide, please. In our research group in the United Kingdom, we have also been interested in understanding deterioration or poor outcomes through a line of work that is referred to as prognostic research. The idea of prognostic research is based on the notion that in any large population of patients, even if these patients have a shared characteristic, a shared diagnosis. So on the screen, you're seeing a representation of a crowd of people. If you imagine that this is a clinical sample, all of whom are patients with depression and who meet diagnostic criteria for major depressive disorder, we could say this is a clinical sample that have one thing in common. They have a common diagnosis. But it's likely that this crowd of people or clinical sample will be very different to each other in meaningful ways. Aside from having the same clinical problem, they may be very different to each other demographically. They may be different to each other in their general health status. They may be very different to each other in their socioeconomic status, etc. And according to prognostic research, these wider sources of heterogeneity or variability between people matter to their treatment response. And that brings us to the notion of prognosis. where we expect that in a large clinical sample, some people will have an excellent prognosis and will respond very rapidly and will have a sustained improvement, whereas other people at the other end of the spectrum may have a poor prognosis. So if you think about prognosis as a spectrum, as a dimension, you can have different levels of prognosis. Some people with an excellent, moderate, or a poor expected prognosis. Coming back to the area of feedback, I have been interested in understanding these not on track cases through this particular viewpoint of prognosis, expecting that the not on track cases are those people located at the higher spectrum of prognosis, so those who expect to have a poor prognosis. Now, how do we do prognostic research? Generally, we follow 3 steps. The first step is to collect information about a large sample of patients at the very start of their treatment pathway. And that information can include demographic, clinical features, personality traits, and other information. We then follow these patients up for a period of time until they finish their treatment. And at that point, we can quantify the extent to which patients benefited from treatment or not. And that leads on to the third step, which involves doing analyses to investigate associations between the patient's features or characteristics and their probability of improvement. Next slide, please. This is a summary of some of these prognostic studies that we have conducted in recent years, where we have systematically identified features collected before treatment that are not only statistically associated with a poor treatment response and with not on track signals, but that there are features that we are confident replicate in different samples of patients, and we've seen them replicate in different studies as well. So we have now a more stable set of observations in the setting where I work. Those features that seem to be associated with poor treatment response could be organized into 3 groups. For example, demographic features such as unemployment, being from an ethnic minority, and being from a younger age, particularly teenagers. These features are, each of them, associated with higher probability of dropout and poorer probability of recovery. The clinical features listed in the middle include comorbidity of other axis 1 disorders and comorbidity of personality disorders, or axis 2 comorbidity. The presence of physical health disabilities and higher symptomatic severity and functional impairment to daily activities. Finally, we have also identified some dispositional features, such as low expectations of improvement and low motivation to change, which also are associated with poor treatment response. Now, you can imagine that some patients may have 1 or 2 of these features, whereas other patients may have 5 or 6 or 7 of these features. And the more features are present in any case, the poorer the expected prognosis, at least from a statistical point of view. So this gives us also some indication of the profile of patients who are more likely to be classified as not on track. Next slide, please. I will now summarize some recently concluded qualitative process research where we investigated reasons for patients being classed as not on track from the perspective of the patients themselves and from the perspective of the therapists who were treating them. The work that I will describe now comes from a doctoral thesis from one of the students that finished her doctorate in clinical psychology last year, Eleanor Williams. In this study, we recruited 28 psychotherapists who were either cognitive behavioral therapists or interpersonal psychotherapists working in the English National Health Service. And all of the therapists that participated in this study were already highly experienced feedback users. We had developed a feedback system and implemented this in the services where these therapists worked since 2018. And by the time we started the study, they had at least 2 years of experience and training on how to use feedback. Just to briefly summarize how they used feedback in this particular system, they were using expected treatment response graphs that you saw earlier in the presentation. And they were sharing these graphs with their patients at every single session, typically at the start of each session, so as to prioritize the investigation of whether patients were on track or not on track, and then to form the agenda and focus of the session based on that classification. The system, of course, is designed to support patients who are not on track. So these therapists were trained to follow this 4-step process if their patients were not on track. First, they assessed possible obstacles, and that means that they had a direct conversation with the patient about difficulties that they may be encountering within the therapy process or outside of the therapy process. And that helped the therapist to generate some hypotheses or ideas about what might be making progress difficult. The second step was the therapists were instructed to consult with their clinical supervisors and to prioritize discussions about not on track cases. That discussion enabled them to move on to step 3, which is to develop a case formulation of the obstacles, to have a very specific hypothesis about what is interfering with progress in this specific case. And based on that hypothesis, they would agree to make some adjustments to the therapy based on the conversation with the patient and clinical supervisor. So it is a very structured and also a very collaborative process of responding to the feedback. In this study, we followed up the treatment of all of the patients treated by these therapists during a 6-month period. And we were specifically focusing on the not on track cases. So during that 6-month period between these therapists, 45 patients were classified as not on track. And we collected qualitative case notes for over 190 sessions from that subgroup of not on track cases. These clinical case notes were structured into 2 parts. So if you imagine an electronic case note system that has 2 windows, in the first window, the therapists were instructed to write open text about obstacles, anything that they perceived to be an obstacle that's interfering with progress in this specific case, and that may have something to do with the not on track signal. The second window in this data collection system was structured to enable therapists to write open text about solutions, the things that they decided to do to rectify or work around the obstacles. That enabled us to collect a very detailed but also very structured qualitative data. Now, those of you who are familiar with qualitative research will know that analyzing line-by-line data is quite an onerous task. It's very intensive, and especially open text data from over 190 sessions is a monumental task. For that reason, we decided to use an innovative methodology that's called latent topic modeling. This is a software, a machine learning software that automatically discovers topics in a large qualitative corpus of data. You may have seen something called word clouds. It's fairly common on social media. If you know what I mean by a word cloud, this is software that reads text data and quantifies the frequency of occurrence of words in the text. So for example, if the word today is mentioned in the text very frequently, in the word cloud, you will see the size of the word today as very large. And let's say if the word tomorrow is not mentioned very frequently in the text, the word tomorrow will appear in the word cloud as very small. So that makes sense to you as a concept that latent topic modeling is an extension of that kind of pattern recognition technology, but it applies that recognition of words to full phrases based on their semantic similarity to other phrases in the corpus of qualitative text. So it's a very neat and advanced way of analyzing large qualitative data sets. Next slide, please. So here I will summarize the results of that topic model. What you can see here on the slide is a network model that enables us to understand which were the most frequent topics that were labeled as obstacles and which were the most frequent topics that were labeled as solutions. On the left side of the screen, you see several red dots labeled O. O stands for obstacles. And the numbers tell you that there were 5 topics that were the predominant topics that captured the information typed in by therapists when they were talking about obstacles. And in the middle, you see 4 dots that are colored blue and labeled S for solutions. So there were 5 obstacles and 4 solutions that were discovered, let's say, through this topic modeling process. I'll now talk through these specific labels. On the right side of this graph, you can see a list that gives you the headings or the titles of these topics and organized by obstacles and solutions. But also you can see that there are some percentages in the colored squares. Those percentages tell you how frequently these topics came up in the whole caseload, in the whole data set. So the most common obstacle was past experiences. When you look at the details of the data, the transcripts of sessions that talk about past experiences, this was often referring to traumatic events or adversity that occurred in patients' early childhood. So it seems that for not on track cases, more than half of these sessions were discussing past traumatic or adverse experiences, which seem to persevere in patients' current difficulties and distress. The second topic is attitudes and behaviors. So this refers to patients not being very engaged with the therapy process. For example, turning up to therapy late, forgetting to do homework in the CBT condition, seeming distant or disengaged from the therapy process. The third obstacle relates to problems with the social network, and this is very similar to Michael Lambert's social support domain. So this related to experiences of loneliness, being socially isolated, but also some of the transcripts within this topic refer to interpersonal conflict. The fourth obstacle was current stressors. So this was very similar to the life events domain in Michael Lambert's model. Some examples being financial adversity, for example, stress related to debt, or people losing access to government support, financial support. The life events that came up in this data set seem to often be about socioeconomic stress. There were some that experienced racist incidents as well. And the last one is therapy factors. So this last and less common obstacle referred to situations where the patients didn't fully understand the rationale for treatment. For example, in the previous session, the patients may have talked about a behavioral experiment in cognitive behavioral therapy, but they didn't actually understand the reason for doing that or what they were supposed to do. Another example is patients not understanding exposure tasks and why exposure might be a good idea. So this is more specific to the treatment techniques, some misunderstandings about the treatment techniques. I'll now move on to the solutions very quickly. So what did therapists do to try to rectify or work with these obstacles? It seems the most frequent approach was the therapists worked very hard to engage therapists and to support them to learn and practice specific coping strategies within the therapy session itself, which seemed to help them to clarify why it was necessary to do exposure tasks or behavioral experiments, and they were more likely to do these as homework assignments outside of the therapy. Focality seems also important in situations where patients have multiple sources of stress and multiple problems. So for example, if they're not only burdened by traumatic memories, but if they're also having financial problems and relational problems, the therapists seem to work with patients to select a focus for the session and to stick to that focus during the session to make maximum impact on at least one of these areas. Whereas it seemed that a lack of focality made progress slower and more difficult. Bridging is also very closely related to focality, but it refers to the idea of having a consistent connection in the topics between one session and the other session. So in the transcripts that we read about bridging, an example would be where a therapist starts a therapy session by first summarizing and discussing key learning points from the last session, and then planning the topics of today's session to have a logical connection to what was learned or gained from the previous session. So that's what bridging referred to. And finally, the last solution that was also seemingly helpful is personalized formulation. Now, this is very closely related to the treatment procedures and training that these therapists received, and I will give you an idea of what personalized formulation involves in the next few minutes. Next slide, please. Now, if we put all of this information together, we have some evidence coming from the United States and other countries, which was pioneered by Michael Lambert and colleagues. So the assessment of signal cases, literature, and findings is one source of information that sheds light on why patients are not on track. The prognostic research that I was describing earlier has also helped us to discover some features that seem commonly associated with poor treatment response. So that's another line of evidence that is illuminating about this area. Finally, more recently, our research group has taken interest in diving into the process of therapy and investigating what happens exactly in these sessions, what are the topics that come up in not on track sessions, what are the solutions that experienced feedback users try out. And this is a third and perhaps more developmental emerging line of research that also sheds light on this process. If we bring this all together, this slide attempts to integrate what we know so far about why some patients are not on track. And we could perhaps organize this into two sections. One section of risk factors, so features or circumstances that we know are at least statistically associated with poor treatment response. And if I summarize that, we could classify a lot of these as relating to adverse past experiences, socioeconomic disadvantage, clinical impairment, meaning very severe symptoms and comorbidity, and interpersonal difficulties. Now, with that background, these risk factors may lead on to difficulties during the therapy process. And those difficulties or processes may relate to the alliance, but here I'm especially drawing attention to Borden's concept of the alliance, which is conceptualized as being made of three things or containing three domains: the relational bond, agreement on goals, and agreement on tasks. I pointed this out earlier in my talk that actually problems with the bond, how the therapist and patient feel about each other and how they get along, seem theoretically plausible explanations for not on track signals, but actually the empirical data doesn't really support that from my point of view. It seems that the not on track signals are more often related to a misalignment of understanding between the therapist, but specific to what are the goals and what are the tasks of therapy, those two elements of the alliance. The other processes that are summarized in this graph, in this slide, are current life problems, for example, financial adversity, low expectation and therefore low motivation to engage with therapy, and finally, social support and conflict. This may give us an understanding of what are the features that lead on to difficulties during therapy and what are the processes that we could target to rectify trajectory of deterioration. So that brings me to my last slide. Next slide, please. This is just a quick example of how we train therapists to do individualized case formulations. This is coming from a forthcoming book that is co-written with my esteemed colleagues, Kim de Jong and Michael Barkham. This book will be published later this year, where we propose a very structured way of making sense of why therapy may not be working so well and coming to a plan about it. The first step is to assess clinically relevant factors. So to ask questions, to engage in a dialogue with the patient about some of the domains that I was referring to in the previous slide. So we use empirical data and theory to guide our questions and to zoom into the domains or characteristics that seem more relevant to that individual. The second step is to formulate, how is it that this specific problem, let's say low expectations and low motivation, how is it that these two things are interfering with progress in this specific case? Once you've come to a hypothesis about that, about how these factors interfere with the therapy process, you would ask yourself in the third step, well, can we change these things directly or not? From my point of view, motivation to change and expectations are changeable things. There are things that we can do to enhance expectations and enhance motivation. But there are some things that are obstacles, life events like bereavement, for example, that we can do nothing about, and we just have to work around it. So that's what the step 4 is referring to. Sometimes these obstacles are directly modifiable, but sometimes they are not directly modifiable. So we have to accept them and work around them. Once you decide what your plan is to either modify or work around these obstacles, you would continue to evaluate progress after you implement your plan using outcome measures with routine outcome monitoring, and you would then review your treatment plan. If the patient comes back on track, according to feedback graphs, then your plan has worked and your hypothesis has been supported. But if the patient remains not on track, that might mean that you have to rethink your treatment plan or perhaps even consider an alternative treatment. So I'm conscious that we only have a few minutes left for discussion. So I think I will finish at this point, and I'll be happy to take any questions or have a discussion about any of these topics.